Hello, my name is Jimmy Fair, and I have a confession. I am an echoholic. I like to use echo to guide my resuscitation on all of my patients, and I'd like to share with you how and why I think echo is the future of cardiac arrest management. When you're running a cardiac arrest resuscitation, you have three basic questions that you're asking. The first, is there organized cardiac contractility? Because if the answer to that is no, then giving chest compressions, which aren't benign, are probably going to help more than hurt that patient. The second question, is there a shockable rhythm? This gets at early defibrillation being crucial to a good cardiac arrest resuscitation. And the third question, what's the cause of this patient's arrest? Because if we have a reversible cause that we can identify, that may change our management in a way that saves this patient's life. So the two tools that we use historically to guide the management of these most critically ill patients are one, the ECG developed by Willem Einthoven in 1903. The second tool we use is two fingers on some soft tissue that we think overlies an artery, and movement of that soft tissue is supposed to represent perfusion of blood. This was developed by Grog, the Neanderthal man, sometime in the Middle Paleolithic era, and that would be fine if Grog's technique were accurate and reliable and were all we need. But sadly, that's not the case. The pulse check is only 15% accurate when we limit it to the 10 seconds allowed by the AHA guidelines. The rhythm analysis, because in part it relies on the pulse check, is equally flawed. So I'd like to highlight one study called the FEEL study, Focused Echo Evaluation and Life Support, which came out in Resuscitation in 2010. If you're familiar with this study, they sent emergency physicians into the field with transthoracic echo, and they compared the initial rhythm analysis with what they found echocardiographically. And 35% of the time, when they thought they had a patient with asystole, the heart was actually doing this underneath. There was organized cardiac contractility. Similarly, 58% of the time, when they thought they were dealing with PEA, so no pulse, they wouldn't expect a perfusing rhythm, they also found organized cardiac contractility. And I know what you're thinking right now. This is some real there is no spoon, question your reality kind of stuff. And you'd be right. It's time for Neo to wake up and question his reality and find out what's really going on in that patient's chest. So the first question, is there organized cardiac contractility? Clearly, echo can show us, as in this case of cardiac standstill, that this patient needs compressions. The second question, can we identify rhythm based on echo? This patient has ventricular tachycardia. See the fast rhythmic motion of that myocardium? That's ventricular tachycardia. That patient needs a shock. Can we identify VFib? This patient has VFib. That quivering myocardium, bag of worms appearance, it's also described. This patient also needs a shock. And in my experience, we're better at picking up fine VFib with echocardiography than we are with the ECG analysis. Can we diagnose reversible causes? Question 3. This patient, brought in as a PEA arrest, had a perfusing rhythm as well as obvious wall motion abnormality. The base of the heart squeezing. The apex of the heart, down here, is not moving at all. This was a big LAD occlusion. This patient has a very dilated right heart, and in the right clinical context, this is very likely a massive pulmonary embolism causing this patient's arrest. And you might argue that we don't diagnose echocardiographically pulmonary embolism. Maybe this patient had pulmonary hypertension before. Well, sometimes we're lucky enough to find that Cheeto-shaped clot in transit moving its way into the pulmonary arteries. This patient is not going to benefit from chest compressions either. This patient is severely hypovolemic. We can see the endocardial walls touching each other during systole. They're completely volume down. In the right clinical scenario, this patient needs either fluids or blood, not chest compressions. And this patient doesn't need chest compressions either. They need a pericardiocentesis to remove all of this fluid that's compressing their heart. So at this point, you might be thinking that maybe you've tried this, maybe you've tried some echo during your cardiac arrest and have found it difficult. You only have 10 seconds to get that window, and the windows are tough to get. Gets gel all over the chest, and you're worried about it delaying your compressions, which is why the obvious solution to this is transesophageal echo. Now, this is a probe that looks scary, but you insert it exactly like you would an OG tube. It's that simple. It has an ultrasound probe on the end of it that sits right behind the heart and gives you constant visualization of what the heart's doing, both during compressions as well as instantly once you stop compressions to see what the heart is doing. No searching around the chest looking for the right window. Your image is already on the screen ready for you to evaluate, making your pulse checks potentially much, much shorter. Just to illustrate how out of the way you are with transesophageal echo, this person in the OR performing a transesophageal echo is up by the patient's head, and they're completely out of the way of where chest compressions and procedures and IV med pushes and all of that would be going on with your cardiac arrest. This is perfectly tailored to use in a cardiac arrest scenario. So back to our 3 questions. Can echo help us with this? Yes. Organized cardiac contractility can be seen with echo and help us decide better whether this patient needs chest compressions or not. Can we see shockable rhythms? Yes, I would argue probably better than we're doing now with our ECG analysis. And then diagnosing reversible causes is really the area where echo has the ability to make large advances and large changes in our decision towards our patient, whether they need thrombolysis or ECMO to get to the cath lab, or fluids or blood or what have you. So with that, I hope you'll experiment with some echo in your practice in your cardiac arrest resuscitations. And I think we have a minute for questions.